that come on the screen now. Hi, everybody. Okay. Thanks for joining me on a Friday afternoon. What else you got to do on a Friday afternoon but study? Okay. So we're going to have a good time. We're going to go over chapter 2, 3, 4, and 5. And we got our thinking caps on, and here we go. All righty. I'm going to share my screen with you. And I sent out the PowerPoints already. So I'm going to share this with you. And let me see here. I'm already back. I'm a single woman. So let me go back up and then we'll get started. All righty. Let me see how. Okay, let me get my big computer here. I don't want to overwhelm you. I might skip over some things just for the sake of time. And if I don't see your hand go up, just kind of say, I have a question, okay? All right. But by now, like I said before, you already did your reading. You're already looking at everything, looking at those key terms. So basically when we started, it seems like so long ago, we talked about puberty. What I want you to know about puberty, it changes. It involves the whole body with these young people. And it not only changes the body system, but also what? The psychic. Okay. And the reproductive system, it gets very complicated, as you can probably tell from now. And it becomes what? Capable of reproduction. That's kind of a scary thing to young people to hear. Okay. And then you have your sex characteristics that start to appear. And don't forget, the sperms in the male become mature now, and the menstrual cycles become regular in females. Although the first period, which is called what? The menarche, right? Well, a young girl gets her first period, and then she might not get her next period for like what? Maybe 3 months, it'd be irregular. In the beginning, when they just start out having periods, it can be a little more erratic. And then it'll get more regular as she matures, the child does. What hormone does the men have that women love to have? Testosterone. It does. It helps a man to develop their muscle mass and his strength. Promotes growth of long bones. And the main thing too, it enhances production of red blood cells. And then, this is how the vocal cords in the male, it changes because of that hormone testosterone. And just like a female, we have what hormones in the female? Estrogen, progesterone, those beautiful hormones. So just kind of keep that in mind. I put this in here because I just wanted to just go over a little bit more of the female reproductive system and the where all the landmarks are, because we talk about the vagina, and then we talk about urethra, and then especially when you're going to catheterize a woman. And so just know your landmarks. I'm sure you do. Just review them. And what I'd like to go over is the peritoneum, because when we get into labor and birth, when the chapter is next week, it is the site of the episiotomy. So going back here, that perineum is right in here, where we're going to go ahead and do the cut if we need to make more room for a baby's head to come out. Okay. And then on this one, I always like to include this because sometimes questions can be concerning about the bladder, and because a woman can be more prone to a UTI. And so the bladder lies right underneath the uterus. And see, the uterus looks like what? An upside down pear. And but when there's fertilization, now I'm going to ask you a question. Where does fertilization occur? Where does
The fallopian tube.
occur? Anybody?
Is it the fallopian tube?
Yeah, fertilization. So remember that, okay? It's in the fallopian tube. And it's like what? In the ampulla, A-M-P-U-L-L-A, ampulla of the fallopian tube. Absolutely. Okay, you got it. And so here it's just a picture again of the fundus, which is the top portion of the uterus, and we use as a landmark. And then here you have what? The fallopian tubes. And so this is what we look like with our three distinct layers. And then the cervix. It's always good to know where the cervix is, right? Because we're going to talk about like placenta previa, late pregnancy bleeding, where the placenta doesn't implant itself in the right place where it should be. It makes its way down by the cervix, and that's what causes her to bleed. So that's what I want you to know about the cervix. And then here we go over the fallopian tubes. And again, this is a safe place, okay, for the sperm to meet the ovum. That's where fertilization occurs. And it's a really nourishing environment. It has a lot of blood, and it's safe for everything to travel. Once it gets fertilized, it travels into where? Into the uterus. Write down implantation. Implantation occurs in the upper portion in the uterus on the posterior wall. That's what you got to know about that. All righty. So here's our ovaries. I found an almond, and it's an almond shape. That's what ovaries look like. And they're the size of a walnut. And the ovaries have two functions. They produce the woman's hormones. They produce estrogen and progesterone. You need these two hormones throughout pregnancy, because estrogen, think of extra. It stimulates, it increases, okay? Think of progesterone, progesterone. It maintains the pregnancy. So kind of try to remember it that way. And you need those hormones. Now, we're going to run right into the type of pelvises that a female has. Okay, so this would be good to remember. The gynecoid is a beautiful shaped pelvis, okay? And you can see how nice that is for a baby's head to fit through. There's plenty of room. See here? Look at that. Very nice shape. But look on the other side. This is what I call my planetoid. The planetoid. That makes it harder for a baby's head to come through. And so this is a very unfavorable pelvis. And this is gynecoid is the most favorable. Okay. Now the android, this is more of a male pelvis. Men have more of an android shape pelvis. And these are important when we examine the woman, because if she has a nice gynecoid pelvis, she can probably deliver a nice sized baby through that. Okay, like even an 8-pound baby. Now you get up into the 10-pound babies, and that makes it tight. But if she has a planetoid and has an 8-pound baby, you're not going to get that baby's head through there, nor his shoulders. So we have to think about that. Okay, so my first question. The nurse is teaching a health class, and she's teaching them about the 4 types of female pelvises. So which pelvis is optimal for the passage of the fetal head? Which one is optimal? Anybody?
Gynecoid.
Gynecoid, you got it. Which one, if the question was which pelvis is not optimal for the passage of the fetal head, which one would you put down? Which one is, or least optimal, I should say?
D.
D, good. Okay, you got it. Okay. Good deal. Now the breast, what I want you to get out here is that, of course, this is where the milk is produced after birth. And it does provide the nourishment. And what else? It provides antibodies for the infant. So write down breast milk provides maternal antibodies to the infant, which is very important because infants are only born with passive immunity for 1 month after birth. That's it. So by giving them breast milk, you're increasing that. And so that's why we try to get at least, I try when I work mother baby unit, I always try to go for the gusto, but at least do for like 6 months to the first year. Get this baby going the right way. Excuse me. All right. Now, we're going to go right in back into the menstrual cycle. And so the different hormones. What you have to remember is the follicle stimulating hormone and the luteinizing hormone. So what they do, it's just like it sounds. You have all those different follicles that are being released. And so this is the hormone that stimulates those. And these all help to stimulate the maturation, the changing, the growth of the ovarian follicle. Okay. Again, you have the estrogen and progesterone. Okay. Now, if you're on a regular cycle, and I'm talking about a regular 28-day cycle, what day is ovulation? When does a woman ovulate if she's on a 28-day cycle? Day what? Day 14. So here's I put this here because I thought it really was a good thing. You see, day 14 is ovulation. Okay. All right, we're going to jump right into the next one here. So when a little girl starts to develop her breasts, we call them little breast buds, and that's when everything starts. And it's during her puberty time, and then she gets her first period, and I call that the menarche. Okay. And then this is when, in the age group, I just put approximately because this could differ, but you get some growth spurts, and then sometimes the hips get broadened. Yeah, little girls, they start to develop, and that's what we see. Okay. Oh, excuse me. I've been sick all week, so I'm sorry, but I'm trying my best to keep it here. Okay, and then I talked about ovulation. It's like day 14. Again, is day 14 that she is very fertile. Okay. So this was my nursing tip, and I think I shared this with you before, is that a lot of times, and I know Hesse kind of likes this, so you might want to put this on the side for Hesse, but a lot of times a young girl will come into your clinic and she needs some sexual counseling. And what you want to make sure that she really understands is that, the survival time of sperm, they can last up in the cervix, they can last up to 5 days. And that pregnancy can occur, intercourse, as long as 5 days before ovulation. So she says, well, I know I'm going to ovulate on day 14 because I have a 28-day cycle. But, she's going to be fertile. Like, she could be fertile like 5 days before the ovulation. You have a sperm, they last that long. So you have to be very careful that she realizes that these sperms can survive. They just get in there and survive forever. Okay, how about we go into chapter 3? So that was a quick chapter 2. Quick. So what you want to get out of chapter 2 is where does fertilization occur? And when's conception? And where does the zygote, when it's fertilized, where does he implant? And you want to know implantation. Okay, so let's discuss a little bit about fetal development here. Well, we all know that our DNA is what our traits are. Okay, we are who we are from our parents, and you had like 46 chromosomes, 22 pairs of autosomes, and then 1 pair of sex chromosomes. What I want you to get out of this is that there's your biological development. When you're a little embryo, it can be altered by like what we call teratogens. And teratogens are substances that can be harmful to a growing embryo. And so we want to make sure that mom's not using drugs, that mom's eating and she's not smoking. So because no matter what, it can cause the fetus, the embryo, not to develop very well. So remember, I already went over fertilization, and is out in the fallopian tube. And here's my good picture, which I just love. And you have your little oocyte here, and you can see. And here's all your follicles. Remember that follicle stimulating hormone I was talking about? Well, here's all your little follicles. So that's why you need the follicle stimulating hormone, the luteinizing hormone. And then it's released, the ovum is released. And then up here now, you see those little things here? Those are sperms trying to get in. How many sperms does it take? One. She only allows one sperm to get into her center. And then she puts like a little aura around her saying, nope, you can't get in there, no more. And then it, under cell division, it divides. And here's your little zygote. And it keeps growing, keeps growing, keeps growing, keeps growing. And it makes its way over into the uterus, into the upper part of the uterus on the posterior wall. And that's called implantation. Okay, I think we got that one. So again, this is just an explanation of the zygote, an explanation of implantation. Okay. Again, this is another good picture. I like pictures. I don't know about you, but I like pictures. Pictures kind of bring everything to light for me too. And so you can see another good picture here of how it fertilizes in the fallopian tube, it travels and goes into the uterus. All right. Now, HCG is a hormone that can be detected pretty early in the pregnancy, usually 7 to 9 days after fertilization. I mean, that's pretty good. So we can do it two ways.
Yeah.
We can do it at urine. Yeah.
We'll talk in school.
Winnie, do you have a question?
No, I don't.
Oh, okay. Yeah, I just want to make sure. And then you can do it by urine, or you can do it by serum. So let me tell you why I would do a blood test. Patient comes in and she's really, wants to know if she's pregnant or not. Maybe she's an infertility patient too. And she's like, I think I'm pregnant. I took a home pregnancy test. I think it's positive. You run a test in your office, and it doesn't show positive, but it doesn't show negative. It's like what we call equivocal. And that one is like, well, she could be, or she's not. And so what I can do is I can send her to the lab and get a serum HCG. And I can run a test on the for the hormone, and I can tell if it's like how much. I can quantify it, and it tells me, and I can qualify it. So I can tell if this lady is pregnant or not by serum. This one, the serum does give you a good reading. But again, HCG is your first one that's out of the bag. I told you the father's sperm is the one that determines the sex of the child. And then you have the chorion, you have the amnion, and those are just two terms I want you to kind of understand, because as we get into more complications in pregnancy, you might hear like a person get really, really sick, a pregnant woman gets really, really sick from chorioamnionitis. And then you would know what part of the uterus is affected by this infection. And then you can understand better, and you can think critically too this way. You can understand why she's so sick. So I just wanted to make sure that you had a good understanding of these terms. Now, I put in red here because it's important. The amniotic fluid itself is clear. It has a mild odor. And sometimes we have Vernix. Vernix caseosa is the nature's cold cream. So if you ever saw a baby come out right after birth, you might see some that have a lot of cold cream, the white, looks like white sticky stuff all over them. And That is to protect the baby's skin while they're in utero. Now, if there's a premature baby, that means they're going to have more vernix. If they're a term baby, they have less vernix. So I just want you to be aware. We went over that. This is an important slide, everybody. So heads up to it. The functions of amniotic fluid. So it maintains an even temperature for the baby. It prevents the amniotic sac from adhering to the fetal skin. And we've gone over this when I first lectured you on this. Imagine if you didn't have any fluid in the baby was stick. You know, it needs something to keep it from sticking. So you have the amniotic fluid. Also, if you want to have the limbs like arms and legs to grow symmetrically, you have to have fluid. So my right arm and my left arm, they grow symmetrically so that they come out to be what? Even. It allows for fetal movement. It allows for the baby to move around into what? Some buoyancy, like, you know, bounce around in there. Excuse me. And then acts as a cushion to protect the fetus and the umbilical cord from injury. So please note that slide. This is the stages of prenatal development. So we have the zygote, which happens when the sperm and the ovum come together, right? That happens in the fallopian tube. Then you have the embryo. So the embryo starts the embryonic development at week 2 and goes to week 8. Okay. At week 9, that little embryo becomes the fetus. And he grows and grows until he's born, until birth. Now, the age of viability. Now, you might hear some people say, oh, it's not at 20 weeks, it's 24 weeks. We used 20 weeks. And so if you see 20 weeks for viability, you know that that's what we're talking about. So 20 weeks, that means viability means that the fetus can survive outside of mom's womb on his own. Now he's going to need the neonatal ICU, granted, yes. Age of viability, it means that he's able to live now outside of mommy's tummy. Okay, and he'll be in the NICU until he reaches 40 weeks. Or usually they set a goal like 5 pounds before they discharge. They'll be in there a long time. They have to catch up to their development. So instead of having mom's tummy to be the natural incubator, they're going to use an artificial incubator, which you see a lot of times in the NICU, and they'll let them develop. Okay, they'll need a lot of help, granted, because their lungs don't have what we call the surfactant, which is a substance that is needed in the baby's lungs in order to inhale, exhale. You know, inhale, exhale. Write down the word surfactant. 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 Okay, that's necessary for that baby to expand his lungs to breathe after birth. All righty. Now, this is the slide I always like. I think I mentioned this before. You can really see from 9 weeks, this is when the fetal stage starts. Remember, embryo, 2nd to 8th week. Now we got fetal development, and this is his time from 9 weeks to 40 weeks. And this just shows you how the different weeks go by and what starts to develop. And you can see here, remember 20 weeks I said was viability, okay? At 24 weeks, that lungs start to develop. That's when that surfactant that I just said to you is developing, it's working. And this is a better time that this baby's going to survive, that it be 24 weeks. because of the fact that the lungs are starting to expand. So yes, viability, we consider it 20 weeks. And then of course, every 4 weeks gets better and better, especially in fetal growth, because the baby gets more mature and his heart is more mature, his lungs are mature. Because don't forget, everything starts here, and then as the baby gets bigger and gets more weeks under his belt, he gets a little bit more mature. All right. This is the placenta. The shiny side is called the shiny Schultz, which is the neonate. That's the baby side. It's nice and shiny. You can see the cord. You have 2 arteries and 1 vein. Remember Ava. And so you can see how nice. Look at these beautiful blood vessels, okay? You can just kind of trace them. So this is where the cord is inserted. So this would be the baby side. And I call it shiny Schultz because that's how I learned it. But it does make sense. It looks new, okay? And then the other side is low globule, and it's called the dirty Duncan. That's the side that's attached to mom, okay? And so it would not look so pretty because it's attached to her, but the placenta served its purpose, providing nutrients and taking away waste. So you want a nice skookum placenta. In order to get a good baby, you have to have a good placenta. Now, if you had a smoker, for instance, and the smoker smoked, you wouldn't see this beautiful placenta. You would see a smaller placenta, and it would have like a gray film over it. It actually does. And then the cord too wouldn't have those beautiful Wharton jelly over it. It has more of like a film over the cord. Okay. So I like this slide because it really lays out what the placenta is all about. The main thing is for fetal respiratory and for nutrition and for waste products. The placenta has its own hormones, and it produces 4 of them. So you have progesterone and estrogen, you have your HCG, and you have your HPL, which is your human placental glycogen. So this slide is rather important, and I would take note for estrogen. Estrogen, remember, extra. I always try to think of something to get my brain to kind of remember things. And so estrogen stimulates, it's extra, it increases. So it increases the blood flow to all the uterine vessels. It stimulates development of the breast ducts to what? To get ready for breastfeeding, for lactation. And so estrogen also can do things like increase skin pigmentation, the linea nigra, that goes to the line. Have you ever been pregnant or seen a pregnant woman? The line that goes right straight up her belly, from the symphysis pubis up to right through her up to her xiphoid process, is called the linea nigra. That's because of estrogen. Estrogen increasing skin pigmentation. She has increased saliva. I've had some patients that have so much that they just have to keep on spitting because they have so much more saliva. Again, the effects of that estrogen in there. All right. Some women have nosebleeds. Again, it's estrogen that can cause that. My other one is that I need to know is progesterone. So progesterone, you need this. So let me give you an example for you to remember it. Estrogen maintains the uterine lining for implantation of the zygote. So when a woman who is trying, or she's now pregnant, but she's low on progesterone, so therefore she might be aborting a baby, we're going to give her progesterone injections. Progesterone injections, and I tell you, they're painful, but they come in every week. And we're going to do that in order that we maintain the pregnancy. So progesterone is needed for maintaining pregnancy. Okay. And also progesterone reduces the contractibility of the uterus. So when somebody who is a habitual aborter, they keep losing babies. That's why we test for the hormones, especially progesterone, to see if she is low on progesterone, because then she would not be able to retain the pregnancy. Progesterone is also, just like estrogen, it helps the breasts get ready for lactation. And so progesterone has a really, really good um, role in pregnancy. It really does. And I tell you, you ever give a progesterone injection, it's an oil-based injection, and it's thick. It's very thick. You have to use a Z-Track for that. Okay. Then the other hormone I talked about from the placenta is HPL, the human placental glycogen. And what it helps make glucose more available for the fetus. Fetus got to grow. So he needs more glucose. And it's more, because why? Because he's growing. He's growing. Okay. All right. So we got the placenta. We talked about it's a temporary respiratory organ. It's a temporary endocrine organ. It takes in blood, right? Oxygen, deoxygenated blood. It also gets rid of waste products. And so we have this coming and going of blood products, okay? And so when blood is like deoxygenated, comes from the fetus, deoxygenated blood, and waste products, because the baby gets rid of his waste, it leaves the fetus through 2 umbilical arteries. So imagine 2 arteries, they have to get rid of all this stuff. Okay, it's a little different than normal person, circulatory system. It's different, it's opposite. And so we have the 2 arteries, which they do a lot of work. Okay, that's why there's 2 of them. And then you have the 1 vein. All right. And I think I got a couple slides on this to help you with that. Of course, I always like my pictures too, because you can see the 2 arteries and the 1 vein. See there? Okay. And it's a lot going on because there's a lot happening. So I put in here for you that fetal blood takes the oxygen and the nutrients before returning to the fetus through the umbilical vein. Okay. You had 2 artery goes 1 vein. Now, anything that mom takes in does cross the placenta and goes right to baby, such as nicotine and drugs, infections. So that's why if mom takes in, it goes right to babies. So here's my beautiful picture of a cord. Again, I put it here really simple. So 2 arteries carries blood away from fetus, okay? And the 1 vein returns that blood to the fetus, okay? So one vein returns blood. And I talked about the Wharton's jelly, okay? That cord has to be protected inside that bag of water, okay? And so there's like a Wharton's jelly. It looks like a jelly. To me, if you ever had apple jelly, it's kind of looks like that. And it covers and cushions the cord. It protects the cord. And then again, the cord, usually, like I showed that picture before, the cord is usually right in the middle of the neonate cord, placenta side. The shiny Schultz is right in the middle of it. All right. So I kind of have redundant of slides here about circulation and how the blood enters into the fetal body through the umbilical vein. So I just kind of letting you know, again, I had to myself, when I was studying, I had to go over this several times in order and draw pictures in order to get this. So again, then you have the 2 arteries that take the waste products and everything and return to placenta through the arteries. It's a kind of a neat exchange, the different shunts that do close after birth. Now, this one, we will talk about these shunts more when we get into newborn, but just be aware, okay, the different shunts, and I wouldn't have to say know it for the test Monday, but just know it that there are different shunts that do have to close after birth. And just know, healthy moms equals healthy baby. What mom takes in, it does affect that baby for actually the rest of his life. So how we can assess fetal growth is by the weight, the length of gestation, how many weeks the baby's growing into, 20 weeks, 24 weeks, 26 weeks, placenta size, and the newborn head. And his abdominal circumference is also considered part of fetal growth when he's born. Let's say, nutrition is so important, like I said, and undernutrition in utero can result in permanent changes in the fetal structure, the fetal physiological status, metabolism. And then also you have to think of chronic conditions that can occur later in life. So do we want to, every generation should get better, okay? So to prevent illnesses of the next generation, this generation now, we have to focus on what? On their health practices and nutrition wise, in order that we have a healthier future. Okay, all right, I'm going to skip over that movie I did on fetal development, but when I put the movies up, the videos up, be sure to watch them. Okay, all right, so that was kind of chapter 2 and 3, real short. I'll talk a little bit about chapter 4, and then we'll take a 5-minute break, and then we'll come back. So chapter 4 is what? We're going to focus on the prenatal care that we talked about that affects the fetus, mom's nutrition, how even mom feels about pregnancy can affect the fetus, and what changes her body goes through. And not only her body, but everybody in the picture. That means siblings of the children, that means grandparents, that means not, of course, dad is affected, it means everybody's affected. All right. By now, you should have a good understanding of the different phases of pregnancy. So you did already your NCLEX questions on the antepartum, that's prenatal, before birth. Then the next set would be intrapartum, which would be during birth. And then the next set of questions would be focusing on postpartum, which would be after birth. So now you pretty well got that under control. You understand how that comes into play. So we keep saying about prenatal care, but have you ever thought, okay, what are my goals for my patient in prenatal care? Well, I want to ensure that I'm going to have a safe birth for her and the baby. When I work labor and delivery, oh yeah, first of all, I want to know she got prenatal care, okay, and how many weeks was she when she obtained prenatal care, and then I know that she got a good start, good health. We're trying to reduce any kind of risk factors so that when we get to the birth process, that that we don't have problems with the fetus or mom. To both keep them healthy. We are into prevention in maternity. We want to prevent. Okay, that's why we're going to get a good obstetrical history, the GTPAL, and we're going to get a good medical history. I need to know, does she have any condition that can get worse during pregnancy? Okay, if I start out with hypertension before she got pregnant, right, then I can judge how by the time we get to 20 weeks that we could see maybe preeclampsia. You see that relation? So I've got to know about her very, very well. And then I'm going to educate her. We do a lot of teaching in OB nursing because we have to tell them how to take care of themselves, how to take care of a baby, because we don't have them the whole time. I mean, they go home, they're going to live their lives. And so I need her to be aware of what she's eating for both her and the baby. You're going to provide physical care and prepare the parents for the responsibility of parenthood. Not everyone is ready for parenthood. And you did a great discussion question this week on the adolescent and getting them ready for parenthood. and nutrition wise, and who we got to get on the team to help this person to accept parenthood. And then you have develop a partnership with parents and family to ensure continuous and coordinate your health care. So these are our major goals of prenatal care. Okay. Right now, too, you have an understanding of the different terms. So gravida, just to make it short, is pregnancy. It's a number of pregnancies that they had. Prima, I like to go to gravida and para because that's how we do our obstetrical history when she comes in every week. We do gravida. So say she's coming in, it's her 5th pregnancy, so she's gravida 5. And she's a para 4 because she has 4 children at home. That's the easy way. Then you have the GTPAL, which you got that down packed now. You got gravida. You got, now we want to know how many of these babies were term, how many babies were preterm. Okay, how did you have any abortions, and how many living children do you have? That gives me a good idea of how this pregnancy might go. So you can say, well, remember, she's a gravida 10 and she's a para, say para 8, then maybe she had a miscarriage. How many weeks were you at that miscarriage? Maybe now her cervix is very floppy. Maybe she's going into labor too soon. That would give me a good clue of how I may have to alter the care for this patient. So again, I just want to give that to you. So gravida and para. And then of course you have your multiparous. And then gestational age is just how far along the pregnancies become. And of course the age of viability, we already talked about that, is the amount of a time in which a fetus can live outside the mom's womb. That's what that is. Okay. And we talked about this already. And I did put here what term is. The term is like 37 weeks to 40 weeks. Preterm is like 24 weeks to 36 and 6/7. And then abortions and miscarriages and your live births. So, this is a good practice one. You go back later and look at it. But, just when you have these kind of questions, just read it carefully and then just put your GTPAL on like a piece of paper, excuse me, and then just plug in what it was. So here she is. She's pregnant for the 4th time. And don't forget to include the present pregnancy. That happens all the time. The student looks through it and she goes, okay, I got 1 abortion and I got 1 term here, 40 weeks, and I have a preterm here at 36 weeks, and they forget about that. What? The present pregnancy. So count that in. Okay. I think you all had that pretty good. And so now, just for review real quick on trimesters, we divide the pregnancy into 3 13-week trimesters. And the reason why is because there's different things that occur at different weeks. And so it's much easier to say, okay, in the first trimester, this is what occurs, which is a hard trimester because hormones are surging. women have ambivalent feelings during that first trimester, you know. So, and it's a change, it's a time of real change. And so that's a pretty hard time because sometimes they have nausea, vomiting during that first 13 weeks because that's when the hormones are at its peak. Then you have the second trimester, then we call that the honeymoon stage. Things are better for mom, and she's come to grips with it. Maybe daddy now is come to learn to accept it, and so it's a good time. It's called the honeymoon stage. And then the last 13 weeks is when mom says, okay, I'm done. I got swollen feet, I'm tired all the time, and they want to just get the pregnancy over with. So that's just kind of a little synopsis of the different trimesters and what happens during that time. All right, and we talked about this already, preconception care, kind of going backwards. But what I want you to remember at preconception care is, of course, it's great to get them in before they get pregnant. Folic acid is something I love to get every preconception patient on. She comes in and she says, well, my husband and I are planning to get pregnant. Great. So we'll start you on vitamins and get you the folic acid. And that's the biggest thing is to prevent neural tube defects. Okay. Claudia, go ahead and mute yourself.
If I had that playbook, I'm doing 3 cups.
Go ahead and put yourself on mute. Thank you. So what I want you to remember of the slide is folic acid. It helps prevent open neural tube defects, such as spina bifida or hydrocephalus. All right, I'm gonna move right along. What's your role then during prenatal care? Well, I'm going to get my data collection from the woman. Got to get obstetrical history, medical history. I want to know about her. I want to know about daddy. Okay. Anything genetically. I'm always thinking I have to evaluate potential risk factors. I'm always thinking very critical ahead. I'm thinking what could happen. So I have to identify that. I'm educating. We talked about this already. Nutrition counseling, we talked about that. And promoting family changes or, promoting the changes that can occur during pregnancy. So that's a pretty big role. And she has to come in for her prenatal care from conception to 28 weeks, which is not too bad. It's every 4 weeks. Now, this is not for a high-risk pregnancy. This is for a uncomplicated pregnancy. And then you go from 29 to 36 weeks, which is every 2 to 3 weeks. And at 37 weeks, now you're getting close to term. So I'm going to see you every week. Now, things can change all the time because you're dealing with healthcare and you're dealing with different people and how she reacts to everything during the pregnancy and how the fetus is acting. So we just want to make sure that everybody gets what they need to be getting in and get on vitamins and get good nutrition and blood pressure's under control, weight's under control, all her lab tests coming back normal. That's a beautiful, beautiful pregnancy. Okay. So this one here just goes over everything I just really talked about is your antepartum nursing care. So here's your obstetrical history. I got the gravid and para. I definitely would know that. Then you got your GTPAL. I would definitely know how to calculate that, which I think you do. And then assist with physical examinations. The Nagel's rule. Yeah, when you're determining a due date, the Nagel's rule is that you take the first day of the last menstrual period and you just count back 3 months and you add 7 days to that first day of the last normal menstrual period. Now, of course, you adjust the year as needed. but that's how you do the due date. It's not hard. You might see that again. So that's the Nagel's rule. Now, we also can do an ultrasound at 10 weeks. Now, those ultrasounds at 10 weeks can be done transvaginally, where we put a probe, we put like a cover over the probe, and we go up the vagina, and we can see the fetus very well. And we get what we call a crown rump measurements. That means the top of the baby's head to his butt. It's called the crown rump. And that will give us exactly that measurement. We have a scale, and we can see how many weeks gestation that fetus is, okay? So it's really neat. That's the first ultrasound. And that first ultrasound usually about 10 weeks, because also we're looking and making sure that we see a heartbeat. Because if we don't see a heartbeat, we could have a molar pregnancy. So we want to see a heartbeat. Okay. And then you get your vital signs, which you want to, get a good baseline, so that you can now see when as she comes back in, if she's escalating in her blood pressure. All right. So I would make sure that you review this slide. These are your kind of like your blood work that happens. So we're going to send, remember I told you, we take a lot of vials of blood at the first go around, because we're looking for HIV testing. We got to know if she's HIV positive or negative, a complete blood count. I want to know about her rubella. So I'm going to do a titer. Because if you ask somebody, did you have the measles, mumps, and rubella shot when you were a kid? I mean, they don't know. So you do a titer to find out if they're immune or non-immune. If they're not immune, that means they don't have any. You cannot give the rubella injection during the pregnancy. You have to wait. Now, you have to wait till she delivers. You can give it to her after she delivers while she's still in the hospital. And the reason why you want to do that is because once you send that patient home, do you think she's going to come back in for a rubella injection? She's going to forget all about it. So this way, we make sure that we protect her and the next baby from getting any kind of rubella. So we want to make sure that this woman gets her injection of rubella because she was not immune. You want to check for hepatitis B, RPR, and VDRL, and RH and blood type. I need to know if she has RH negative blood or she's RH positive. Because if she's RH negative blood, she would have to get an injection of Rogam. So I want to make sure that I get that tested. I know what I'm dealing with, so I can guide her and make sure that she gets her Rogam injection. I'm going to do a pap smear and maybe some cultures. Make sure to rule out any kind of gonorrhea, chlamydia. The reason why is because these can cause infections to mom, especially during pregnancy, and she could lose the pregnancy. And then you want to test if there's sickle cell or hemoglobin electrophoresis, and of course do a urinalysis, because I want to make sure she doesn't have a UTI, because that can predispose her to more, maybe going to polynephritis, which would be up to the kidneys, which could cause her to lose, go into preterm labor. So we don't want any of that. So I want to make sure that I do all this blood work so that I can go ahead and, get a good hold on it. And also, if she's anemic, I need to know hemoglobin hematocrit, because, a lot of women are anemic. They don't eat right. They want to look very skinny and cute, but that may be that, she's not eating properly. So now she's anemic. And that wouldn't be good, because the baby needs mom to have adequate amount of blood circulating, because blood has oxygen in it. So you want to make sure that mom has enough. All right. And then, you do your recommendations of your foods. Okay. We're almost going to take a break here. So these are routine assessments that are done at each prenatal visit. All right. So we talked about this already. Blood pressure, pulse, weight, urinalysis, blood work. I'm gonna monitor for anemia. The fundal height, measuring fundal height, because I could tell fetal growth. Even amniotic fluid volume. Is it oleohydramnios, which means I don't have enough amniotic fluid, so my fundal height would be off. Or do I have too much, which would be polyhydramnios, which would be too much fluid, and my fundal height would be increased. And then, you know, you can tell by putting your hands on mom's tummy if the baby's in a vertex presentation where the head is down, or the baby's breech. I can tell. And it's always good to be able to tell your patients what could breech, you know, well, we can give you some exercises that will help move those babies around as they grow, as they keep growing. Fetal heart rate, just make sure that you just remember 110 to 160 is normal fetal heart rate. Anything below 110 is bradycardia, and anything greater than 160 is tachycardia. We talked about nutrition already. And of course, any problems since they've been to see us. But especially in the beginning, remember, from concession to 28 weeks, they're only coming in every 4 weeks. So a lot of stuff can happen in 4 weeks. All right. This is just another slide that goes over your increase in your calories and increase in protein, and then increase in vitamin A, vitamin C, of course, calcium. And then, of course, make sure mom's drinking plenty of fluids. So I think we got that. We talked about Nagel's rule already, so I got that in here for you. If you need to review it some more, here it is. And okay, so here's your signs of pregnancy. Now, I would know this. And so if you're still not sure, be sure to write a little chart down. And maybe you're writing it will help you. But you need to know these signs. You have the presumptive, you have the positive, and you have the probable. How you can remember this? You're probably saying, give me some tidbits. Well, on the presumptive, you see the you. That means that's the person. That's you. Okay, that's your patient. That's her. Okay, so this is what she's telling you. Well, I haven't had my period. I've been nauseated, have some breast tenderness. I kind of go to the bathroom a lot. Okay, now, it's presumptive because she's telling you, well, this is what I'm feeling. But are they really, really, really concrete signs? Not really, because other things can cause them to have these things. So these are presumptive. Good chance of it, but still is from what the patient, she's telling you. Now, with probable, this is now is the examiner is going to be examining the patient. So this is what the examiner sees. So he sees like the Quidel sign, which is softening of the cervix, or maybe a Chadwick sign. That's a sign I like, because you put the speculum in and you see this beautiful purplish, reddish discoloration of the cervix. All that vascular congestion down in the cervix area. This is such a vascular area. You see this beautiful discoloration. That's the examiner. Okay, that's the examiner. Now, the positive sign, pregnancy, and you can't dispute this, is when you see the fetus on ultrasound. Okay, there's an ultrasound picture, and you got the little fetus floating in the amniotic sac, and so that's pretty positive.
Mid-size is nice, but you could do this.
Sabrina, go ahead and put yourself on mute. Okay, and so you can hear the fetal heartbeat, you can see the fetus, and then when you have the examiner has his hands on her belly, he can feel it. That's pretty positive. You can't get anywhere away from that. It's pretty positive. So I hope that maybe saying it that way could be more helpful to you. And then here again, this is how I put it for you. So you can see the U is what she's saying. Okay. This is what she's saying. So, you know, all these things she's telling you. Okay. That's presumptive. And then the probable, we talked about this already. It's another slide that I outlined it for you as to what each one is. And I would definitely take note to Goodell's sign, the Chadwick sign, know what they are. So the Goodell sign is just a softening of the cervix. You can see that. And again, it's a congestive area. And then the Chadwick, I talked about that already. Okay. And here this is your positive sign. That's your ultrasound. Okay, so we already went over that pretty well. And this is another slide just to summarize exactly what I'm trying to get across is the different signs of pregnancy. And I think we got that pretty well taken care of. Okay. And then
Why? You don't like it? Why?
no, go ahead and put yourself on mute. The normal
Yeah.
changes in pregnancy. Well, just kind of have an idea of what is going on in the body. And I don't know, I usually draw like a stick figure of a woman, and then you can put down like the endocrine system changes. Remember the placenta is a temporary endocrine organ, and you have the large amounts of estrogen and progesterone. Okay. And then, you have changes going on in the uterus. The uterus will grow bigger. If the uterus is growing bigger and it takes up a lot of space in the abdomen, then it's going to press against the lungs, kind of push them up. So she'll have, her breath sometimes will increase. She has to take in more oxygen, and consumption is more. Sure. The cardiovascular, the circulatory system increases by 45 to 50% in blood circulation. And that's because the fetus needs it too. So again, her heart rate is going to go up. That has all the changes that you see. The GI also displaces the stomach because the uterus is growing. There's only so much room in that abdomen. And because now the uterus is considered to be an abdominal organ. So the uterus displaces the stomach and the intestines. And this is why she gets heartburn. She can't eat a full meal. She has to eat small, frequent meals. It's because of the uterus growing. And then you get like marks, like from the hyperpigmentation we talked about. And so you get those stretch marks, you get linea negra, you get the chloasma, where, chloasma is called the mask of pregnancy, but you can also get it on your forehead, comes all the way around, and it looks like a regular mask. That does fade away. The linea negra fades away. The stretch marks do not fade away. They stay with you forever. And also another change would be the safety issue with a pregnant woman. No more high heels. We need stability, because we get what we call a waddling gait. And I would write that term down, waddling gait. And that's because the pelvic joints are so relaxed. They have to be in order to accommodate the growing uterus and to get ready for what? For delivery. So she walks a little funny, almost like we call what? Like a duck. Okay. All right. Let's see here. We go on. We talked about some of the other changes in the reproductive system, the mucus plug. The mucus plug is to prevent from the bacteria from ascending up into the uterus. So it does its job very well, because when she loses a mucus plug very early, then she's more open to infection. And that's where you can get the inflammation of the chorion and the amnion that we talked about earlier. And that could be bad for the fetus, because that would also cause the fetus to be infected. Alrighty, let's see here. This is this comes right out of your textbook. And what I want to show you is, here's your the provider measuring the fundal height. So If she's at 20 weeks gestation, okay, means 20 weeks into the pregnancy, then she should measure 20 centimeters. It correlates right with the gestational age. Centimeters goes with the gestational age. When it doesn't, and so if she's supposed to be now 26 weeks, right? She's supposed to should be up here, and she's only measuring 20 weeks. Think about it. What's going on with that baby? That baby's not growing. And so we have small for gestational age baby. And so why isn't the baby growing? So we have to go on maybe with an ultrasound. It's like, what's going on with this baby, okay? We can also determine when we do that ultrasound, we can look for pockets of fluid and determine if she's got enough fluid. So this is a non-invasive way. It's real simple, but it does give us a lot of information. Okay. And so you can see up here by 40 weeks gestation, how much the ribs kind of flare out. Everything is pushed back. The stomach, the intestines are pushed toward the back. And you can see how this would take up her whole abdomen. So it's kind of uncomfortable for her. And how they measure is they just take a simple little measuring tape, and they start at the symphysis pubis, come straight up on the linea negra, and they feel the fundus. They're feeling for the fundus here. And when they find the fundus, they're going to put the other piece, the end of the tape right there, and measure. And we do that at every visit. Every visit. The patient comes in, we're going to do a fundal height. It does give us a lot of good information that we do need. Going over the respiratory system, I kind of welled a little bit already, but we talked about the ribs flaring out, oxygen consumption, about 15% it increases, the diaphragm rises, increased estrogen. There's your increase in your estrogen. You have your edema causing some swelling. Remember I talked about the mucous membranes, like a nosebleed, estrogen. That's also a good test question. And then nasal stuffiness could be also from that, estrogen. We talk about heart and about 45% increase in blood volume. And because mom needs good blood volume in order to withstand what the baby needs. Because don't forget, there's a whole system going on down inside that uterus with the placenta and the two arteries and vein, and the amount of oxygen going through there being delivered to fetus, and fetus returning it back through the placenta so mom can get rid of it. It is a very, very efficient system, but mom has to have adequate blood circulating in order to withstand it. Okay, so that one leads us into now supine hypotension syndrome. Heads up, you might see this again. You never ever put a patient who's pregnant on her back. So I put this nice picture of a patient laying on her side, preferably the left side. Keep her off her back. And on the left side, you get more blood perfusion. So we want to get mom the best circulatory system, blood going in and out of these two, and also for fetus. So we want mom not to be on her back, because mom, if she lays on her back, well, first of all, she's going to get very agitated, just can't breathe. And then she feels funny, feels kind of fainty. And then sometimes you get real lightheaded on you. And you go, oh, no. And then, get dizzy. So what are you going to do? Turn her to a left side. That's all you have to do, is get her off, get the pressure. Remember we talked about that vena cava syndrome? Get her off. See how that uterus is laying right on that inferior vena cava and just compressing it. So this would be bad. And baby would get affected. Baby would have problems with his own heart rate because he's not getting what he needs from mom. Mom getting depleted. Mom gets depleted. Baby gets depleted. It's kind of, it's a good system. So we don't want mom to be anemic because she can get a condition normally in pregnancy because of hyperdilution of blood. It's called pseudoanemia. So we don't want her to get depleted because she needs that. She needs a good amount of blood. You know, we want to make sure that she gets up, you know, pushes off on her sides and she doesn't get, you know, just jump up, that she get that orthostatic hypotension. And it can go fast on you too, especially in pregnancy. Don't want to, no, I don't want to have any palpitations because that can happen with cardiovascular systems. And then we want to make sure that, you know, she has any kind of a preeclampsia, that we're looking at coagulation studies. And because we don't want her to throw a thrombus because she's at more risk for that. So we want to make sure that, you know, we have all this under control. So again, we have to be careful of the cardiovascular. So we have to be careful of the respiratory, the cardiovascular, the GI system, like because of the growing uterus. We have to be careful of the kidneys because the kidneys are getting a lot of pressure. Same thing. And it all kind of affects everything. As the uterus grows, it affects everything. So remember back on that first chapter, in chapter 2, that we talked about the anatomy and physiology. And I said, I want you to know those landmarks. This is why, because you can see here we have a normal system. We don't have a pregnant uterus. This is a non-pregnant uterus. So you can see everything, but see how when she gets pregnant here, what happens? And see here as the baby grows, see how now everything is pushed way up. Look at that liver. The liver is just like flat as a pancake. And so you have to think about, you know, all this pressure when now she's term. All right. On the urinary, the kidneys, we just talked about a little bit. They're more susceptible to urinary tract infections, which can lead to preterm labor. So I want to make sure that every time she comes in, that I'm looking at and testing her urine for any kind of WBCs, which are white blood cells, or nitrites, which are present when you have a UTI. All right, heads up, everybody wake up. Women of normal height, okay, so their normal height, they gain 25 to 35 pounds. Write that down. Normal weight gain during pregnancy of somebody who is of normal height is 25 to 35 pounds. Now, if they're overweight, then they're going to have to decrease a little bit. They're going to have their weight gain can be from 11 to maximum 25, okay? And then obese women, they have a tough time because they're really restricted and they can only gain a maximum of 15 pounds. Well, special nutrition considerations, of course, remember the adolescent, as you're discussing in discussion 2, they have their own special nutritional needs and where you can refer them to. We have to make sure that the vegetarian, that they're getting what they need. Pica. Pica is a non-food substance, such as like chalk or soil. And, you know, it's always good to know how much of this stuff they are eating, you know. They're going to eat it, you know, it's called pica. That's what it is. It's non-food. So, you know, you're not going to get after them going, oh, you shouldn't eat that. They have a craving and they don't really want to do it, but they have a craving for it. And for example, I know a patient that had a craving for soil. And so she would have a little area in her backyard. And she had her little flower plants and she had soil in there. And she would eat the soil. Now, it's hard to even fathom that because, you know, when you're not pregnant, you know, these things are not, you know, you don't crave these things. But when you're pregnant, it does happen. Okay. Let's see. So just remember that during lactation, breastfeeding, you get an extra 500 calories, which is a good thing. So pregnancy, you need at least 300 more. Lactation, you get to have an extra 500. That's how I usually get women to breastfeed. So I say, 500 calories that's a lot of good calories. You can eat a lot in 500. So they go, oh yeah, that's good. I'll breastfeed. And so I just try to get them to do whatever I can to get them to breastfeed. So just remember that 500 calories. Exercise. What I wanted you to take away and remember about exercise and pregnancy is that we're not running a marathon. It's just for maintenance of fitness. It's better to go walking even for 30 minutes a day than do absolutely nothing. So just exercise, just to maintain. And I told you the other day that my patients that did go and exercise, at least walking, did experience an easy, like not easier labor, but they could tolerate the labor much better. All right. Travel. You can travel during pregnancy, but up to when you get to be 36 weeks, that's the time to say, okay, I'm staying home. 36 weeks is your cutoff time. And the reason why is you don't want to be sitting for a long time. Then, got to get up, walk around. And also, you want to make sure that if you do travel, you get maybe buy the seat that has a little more leg room. That's also very helpful. And you want to be drinking your fluids. So you want hydration even before you go on the plane. So that's okay, because then you have to go to the bathroom on the plane. So that means you have to walk up and down the aisle. So that gets you out of the seat. So that's a good thing too. But got to make sure too that, if you're traveling, that you take your obstetrical history with you. So you can show where if you get into problems in another country or another state, that yes, I did get my prenatal care stay in New York. I'm in Florida having vacation and I went into preterm labor. Then I can see what blood work she had done, where she's up to, and it's much better. I don't have to start all over again. So you always want to give them a copy of the obstetrical record. Okay. Just a slide here that goes over the common discomforts in pregnancy. Fatigue always can be the very beginning and at the end. Nasal stuffiness, that's an estrogen surge. Nausea in the beginning of pregnancy, especially in the first trimester, can happen until the hormone itself, progesterone, seems to go down. Heartburn, yeah, it happens later in pregnancy as the uterus grows into as a dominant organ and puts pressure on the stomach. You get some heartburn, constipation, hemorrhoids. Yeah, just because the extra pressure, extra weight, those are all delicate areas that the tissue can just blossom out and cause a lot of discomfort. These are discomforts in pregnancy that are very discomforting. I mean, they're hard on the patient. Backache, vaginal discharge. You have that leukorrhea. You have more mucousy type discharge. Varicose veins, more stasis happening. If you get more edema, especially estrogen can cause that. So you want to make sure that you keep moving. Fatherhood. Now, I want you to make sure that you understand about fatherhood and that there's different ways that they adapt. So it's called the developmental stages of fatherhood. They have the announcement when the pregnancy is confirmed. Okay. That's when she tells him, well, you're going to become a daddy. Okay. Same thing. He's got ambivalence too, don't he? And so he can be shocked or, can be very happy too. They were trying to get pregnant. And then they go through acceptance where they accept, the pregnancy, and then adjustment and focus. Okay. And so again, these are all kind of developmental of the father, how he will accept the pregnancy. And more dads are doing that now. The adolescent, what's the impact? What kind of concerns would they have by the adolescent? Well, they're going to have different roles, right? Yeah. They're going to have nutritional problems, you know. They might be trying to hide the pregnancy. So they have their own particular needs. You know, it's hard to get an adult to take a vitamin every day. It's hard to get an adolescent to take that same vitamin. So they do have their needs, and they have to have a lot of encouragement from the nurse and as a team. You know, maybe get a dietitian in there, get her some support. You want to know is how home is doing? Is mom and dad accepting the pregnancy? Sometimes mom and dad doesn't even know that they're pregnant, and teens are able to cover up a lot of times the pregnancy. It's a hard time. You know, it's very stressful on the teenager that's pregnant. And then also, if mom is having stress, also the fetus is experiencing the same stress. So it's not easy. The other group is the single parent. She's all by herself now. She could be a mature woman. You know, you have the adolescent by herself. Now you have the mature woman by herself. She's on her own. She's trying to, you know, continue to work. She's got to survive. She's got to pay for her rent, her own food. And so they have their own special needs and concerns. All righty. The immunization of pregnancy. What I want you to remember is that you do not give a pregnant woman a live virus. They are contraindicated during pregnancy. And the big one is rubella. It causes so many problems to the fetus. And so you do never give a live virus to a woman. Now, you never give mercury poisoning to a woman. You never give anything that has thimerosal in it, which has mercury in it. So you don't give that to it. And I like I said before, I think I'll reiterate here, is that you avoid pregnancy for at least 1 month after receiving the MMR. Now, say she's not pregnant. Excuse me. She's not pregnant. NOT. And so, you know, she's not immune. So, you know, okay, so she's not pregnant and she's not immune. So you're going to give her rubella. You have to tell her she cannot get pregnant for 1 month after receiving that injection. She cannot get pregnant. It is very, very important that she does not get pregnant. So you can see why, because rubella is a live virus and it can do a lot of harm. It can do a lot of harm to a fetus. And so we keep away. We keep away from that. Okay. Be sure that you read in chapter 4. I put down page 78, 78 to 81. It is a summary table of the signs and symptoms that occur in pregnancy, both physiological and psychological, which is good. And how I like how it did it. It divided the 3 trimesters. And that's what I was talking earlier to you about. What happens the first trimester, second trimester, and third. Don't forget, you know, your book has the unfolding case study. Those are really, really good. And it goes now, it'll go all the way through to the end. So you might enjoy that. I do. All right, I'm going to stop here and take a break. We're up to chapter 5. I need a little break because I'm getting kind of congested here. Let me see, what time is it? My watch don't work.
It's 4 o'clock.
Oh, it's 4 o'clock. Thanks. My watch stopped. How about we take a 10-minute break and then let's go into chapter 5. That's the chapter I wanted to get to. So take a 10-minute break and then we'll probably come back on 4:10 and then probably take them till 5 o'clock to get the chapter 5 in. Okay. All right. Take a little break, everybody. Thank you. resume. Here we go. Here we go, chapter 5. Okay, so now you're going to jump right into taking care of women with complications during pregnancy. So, the other day I told you all to know about the danger signs of pregnancy. Here they are again. We went over these, but I'll go over them real quick because they are important. So if she has a sudden gush of fluid from the vagina, that means her bag of water just broke, okay? And it's a danger sign because you say she was early in pregnancy, she could be losing the baby. Also, when you do lose water from the vagina, she could have a prolapse cord with that. So we always put it as a sudden gush. Vaginal bleeding in early pregnancy, you're always like a threatened abortion, inevitable abortion, and that's never good. There's signs of early bleeding. The signs of bleeding in late pregnancy is associated with placenta previa, which is painless bleeding and painless red bleeding. And then you have the other one I wanted you to know was placenta abruptio. That's in late pregnancy. And that is because the placenta now abrupted off the endometrium, the wall of the uterus. That's never good. Okay. That's painful bleeding. Okay. Abdominal pain. Early pregnancy could be she's having abdominal pain related to ectopic pregnancy. That's another danger sign in pregnancy. Ectopic. Got to get that, identify the possibility of an ectopic pregnancy, because if I don't, and that tube ruptures, she could lose that tube. So again, that's never good. Persistent vomiting, that's your complications, as such as hyperemesis gravidarum, which happens, can happen during the whole pregnancy. That one can last the whole pregnancy. The nausea, vomiting in pregnancy happens during the first trimester, the first 13 weeks, related to the insurges of the hormones. Epigastric pain. Remember I showed you that picture of the liver, you know how when the uterus now is in the abdominal cavity and it pushes everything up and pushes that liver up, the liver looks like a pancake. That is right underneath the right breast. That's where the liver is. Epigastric pain is never good, especially as associated with preeclampsia. That's a bad sign. Your patient starts complaining of that. That means that her condition has gotten a lot worse. The edema of her face and hands, you can see that. That's also associated with preeclampsia. Severe persistent headache, again, preeclampsia. Blurred vision or dizziness. These are all signs that a woman's getting very sick, and that is associated with preeclampsia, which is high blood pressure in pregnancy that shows as bad face. I say bad face after 20 weeks. And that's because it's been studied where the relationship of the placenta is the culprit. It's the one that's causing it. Because what is the cure for preeclampsia? The cure for preeclampsia is delivery, folks. So that's why we're studying it. And studies are going on now about causes of preeclampsia. And then chills, you get a fever 100.4 greater, which is never good because mom gets a fever. Who else get a fever? Baby's heart rate will go up, and you can have fetal heart rate say in the 170s to 180s, and you got fetal tachycardia. And then, of course, painful urination or even reduced urine output would be indication that she's got a cystitis, urinary tract infection, or she had polynephritis, which if you don't get it when it's just in the bladder, it's a cystitis. It can travel up and go into the kidneys. So these are danger signs of pregnancy that we take very serious. Okay. So here we're going to talk about an amniocentesis. Now, what I want you to remember about amnio, you might need to see this again, you might see this again, is that we're taking samples of in the bag of water, we're taking some fetal cells. And so we have this like long, very thin needle, which is thinner than what this picture is. And under ultrasound guidance, we go and we're visualizing the fetus and we can see those pockets of fluid. And that's where we're going. We're getting out some samples. And we do an amniocentesis in the beginning of pregnancy in order to identify chromosome analysis. We're looking at the chromosomes, the makeup. So write that down. Amnio in the beginning of pregnancy is for chromosomal analysis. We're looking at the makeup of the fetus through the chromosomes. And we can pick up abnormalities. And we do that especially on advanced maternal age, women who maybe are sick. And so we need to know what the chromosomes are up to. We go ahead and do an amniocentesis. Now, it comes with side effects. Yeah, we're going into the uterus like this. We could, one, the baby could abort, okay, because the bag of water could break, could get remember the sudden gush of fluid. She could, the fetus could die, and she could contract. Her uterus could start contracting. So this is a test that, although it's very good, we have to do it knowing there's a lot of side effects that can happen. Okay. So it's a good, interesting slide here I put here because I want you to be aware that we're looking at fetal genetic diagnosis. Okay, now we can do, and here I want you to remember this. I think I said this 3 times. Is that pretty important? I think so. Now we can do it later on in pregnancy. And I mentioned this the other day. So say she's around 32 weeks. And we're going, maybe she's got preeclampsia. And so she's getting sicker and the baby's not growing and mom's blood pressure keeps escalating, even though we're giving her magnesium sulfate. So it's not a good situation for mom or baby. So we're going to go ahead and try to get her delivered. They can do an amniocentesis to see how much surfactant or lecithin there is in the fetal lung. So, because it's a circulation of fluids. So we can go in there, get some fluid out. We're not going into baby's lungs, we're just going to the amniotic sac and see if we can determine the presence of surfactant. And then we know that the baby has a good chance of surviving outside the womb by the amount of surfactant that's being secreted. Remember, I told you surfactant is that kind of that lubrication that's needed by the lungs in order to expand and deflate, okay? So that usually is produced around 24 weeks gestation. So if she's at 32 weeks, she's had several weeks where it should have been circulating, but we don't know we have enough, where we can determine that by doing an amnio. Now, doctor may say, I'm going to deliver her anyway because she's sick. And we know the cure for preeclampsia is delivery of the baby in the placenta. So, sometimes they do it for that reason, and sometimes they don't, because again, we're going to deliver her anyway. Because, you can't let a patient just get sicker and sicker, because the baby will not grow anymore and the baby will get sicker. Okay, so these are your complications, and I think you've got pretty well got them down packed now. It's your hyperemesis gravidarum, excessive vomiting in pregnancy. Oh, you have to worry about electrolyte imbalance. Oh, it's terrible. It really can take a hit on the family. It's all the way through the pregnancy. I told you about my patient vomiting at time of delivery. It it just very hard. There is more studies on what they're looking at and how they're handling hyperemesis now. It was on the Today Show just recently, and I was pretty impressive that we're actually looking at this condition because more women are getting it, and so that's good. It's not good that there are more women are getting it, but it's good that we're getting more research. And then bleeding disorders. We talked about early pregnancy and late pregnancy bleeding. And then you got hypertension, you got gestational hypertension, you got your preeclampsia and your eclamptic patient, and your blood incompatibility between mom and the fetus. That's your RH. Mom is RH negative and baby is RH positive. Okay. So those are your complications. So here on all my different slides, I have what goes on, how we can correct it, and what should be given. So what I would do is I would highlight now the different drugs that it could be given to help a person get through. Reglan is good. Zofran is very good. Phenergan we talked about the other day. That's a good drug. They're gonna definitely have an IV, and we have to do labs in order to watch her electrolyte imbalance, because you can get heart condition related to electrolyte imbalance. So is it dangerous? Yeah. And is it uncomfortable? Yes. Does it impact the family? Yes. Does it impact fetal growth? Yes. Okay. And so the fetus always needs oxygen, nutrients, mom's blood to keep going. If mom is being depleted and she keeps throwing up and she keeps having electrolyte imbalance, the baby's going to be affected by that. So sometimes you have to do a TPN, total parental nutrition. They got a feeding tube. And another one is a pump where they deliver Zofran or Reglan through a pump. It's like if you ever seen an insulin pump, it's sort of the same kind of pump, and it has medication in it. And what it does, it keeps mom at an even level. Because when you do like medication, you give a shot, right? And she feels the effects of the first shot. Good. But each time you give an injection of the same medication, the effects of that shot, the same dosage, gets lesser and lesser. It's because her body is getting, her receptor sites in her body get used to it. So what happens is that you get it on an even level, such as a pump that delivers a control amount, you have her more regulated. It makes sense. Okay. Let's see, the next complication we're going to discuss is the bleeding disorders. And these are in early pregnancy. And so we've got the spontaneous ABs, and we have what we call threatening. That means that there's a threat, okay? There's a threat, but it's not totally happening. So what we can do is put her on bed rest. So she might have like some mild cramping. She might have some bleeding, some spotting. It could be brown spotting. It could be, red spotting. It could be a mixture, all right? But if we put her on bed rest and nothing in the vagina for like at least 2 weeks, okay, everything goes very, very calm, very smooth, then a lot of times where that blood was, when that was coming out, it heals up and it seals itself. So then she can hold that pregnancy, which is a good thing. So that's your threat. And I would definitely remember this term. The next one is inevitable. That means, I got ruptured membranes, I've got lots of blood. I mean, it's going to happen. Just a matter of exactly when she's going to pass the tissue. So there's nothing I can do. And then you have incomplete AB, where she's lost some tissue, but she hasn't evacuated all the contents of the uterus yet. So then she needs a DNC. So you keep your patient NPO so you can get her ready for surgery for DNC, dilatation curettage, and we just go ahead and clean out the entire uterus, make sure it's nice and clean, and it will go back down to normal, and then she can start all over again. It is hard for patients to lose pregnancies. I mean, you're losing a baby. So what's your nursing care? Well, you want to definitely, give them supportive care, just like any grieving mother would be. She's crying. You want to always, whenever you have bleeding, I don't care if it's abortion, deliveries, any kind of bleeding, gunshot wounds, you always want to document the amount and the character of the bleeding itself. You want to save anything that looks like a clot or tissue. So like if I got a patient that is miscarrying and she wants to be at home, I'll give her like a sterile container, and I'm saying when you feel the urge to bear down, put the little container underneath, and the contents will go right into the little jar, and bring that into us, and we'll send it to pathology, and the pathologist will look at it and examine it. You always want to estimate your amount of bleeding, and you want to keep track of it in order that you can give a good report. You always want to look at vital signs. And always, if your patient is actively bleeding, you're gonna keep them NPO, because they may have to go to surgery. So that's the worst thing you want to do, is feed somebody, and then the surgeon says, I really need to take her to surgery to get this out. And you go, uh-oh, I shouldn't have given that water to her, or a soda. Okay, now the ectopic. We talked about ectopics before. So 95% occur in the fallopian tube. Okay, now they can go elsewhere, but 95% occur in the fallopian tube. And we talked about that, where they get stuck in the tube. It could be from scarring in the tube, adhesions. It could be that there's inflammation in the tube. She could have a congenital defect. It just doesn't get through all the way to the uterus where it needs to go. It gets stuck in that tube, and it just keeps multiplying. And we said, I think I got a picture. Yeah, it just keeps multiplying, and it just gets stuck. Okay, remember the tube. It's not like this picture where it looks really nice and fat and big. It's kind of flimsy and thin, and the diameter is not very big, and so for it to get stuck in there can happen. That's why sometimes women who try to get pregnant have their tubes cleaned out, because sometimes that's why the zygote didn't make it to the uterus. Okay, so that's a topic. The sooner the better you get the patient in to the hospital for ultrasound, the better. So you want to, patient calls in and you're on triage that day. And so, you say, okay, she's an age reproductive. She could be reproductive. So when was your last menstrual period, ma'am? And she says, oh, about 7 weeks ago. And she says, but right now I'm having this lower abdominal pain, nurse, and it's really grabbing me. I got some vaginal bleeding going on. I'm not feeling too good. I'm kind of sweaty. What are you going to tell her? Well, I'm going to tell her to go to the hospital. What are you thinking? I'm thinking ectopic. So get her to the hospital, because the sooner you get her to the hospital, the more she can have the ultrasound. And take note, what kind of ultrasound do they do? A transvaginal, where they take the probe, they put a plastic sheath over it, and it goes right up, and they can see exactly where that pregnancy is. And so they do a transvaginal ultrasound. They find that she's got ectopic, but we caught it. You got her to the hospital in a great amount of time. Really great. She's not going to lose her tube. They give her a medication called methotrexate, and methotrexate inhibits cell division. So it kind of attacks those cells and keeps dividing, because those little cells, they don't know any better. They just keep dividing. And then what happens is you get rid of those cells, and it gets reabsorbed, and you save her tube. Is she happy with you as a nurse? Yes, you saved her. You saved her completely. Okay, so these are some signs and symptoms of hypovolemic shock. Just be aware of them. I think we went over this the other day, but tachycardia, when like this patient here who has ectopic and she's like having all these problems, such as all the severe pain and she's getting sweaty and clammy and she's not feeling good, she's going into hypovolemic shock. And so her pulse gets tachy, her breathing gets faster. She's having trouble with breathing. She's trying to catch her breath. Her blood pressure is, going down, and her kidneys are saying, "Hey, I need some more blood here." But the body knows best. The body senses that something's not right, so the body takes the blood that's circulating, instead of going to all the different organs like it normally does, it sends the blood where it needs to go to keep the patient alive. So that's why you got decreased urinary output. And of course, on the outside, she's now not circulating blood, her skin gets pale. And then, of course, she gets cold and clammy also. So your patient's in hypovolemic shock. Now, this is a good slide to kind of keep in mind, because you can use that in med-surg too. We talked about identifiable mold when you're at the 10 weeks and you're going for that ultrasound and there's no heartbeat. Remember? And so it's also called trophoblastic disease. And what it is, it's just a bunch of cells that didn't formulate a fetus. Okay. It just kept cell dividing, doesn't know any better. It made its way to the uterus, but then nothing formulated. And so now you don't have anything and you just have a bunch of cells. What you have to be careful with that, let me make sure my speaker's working here. What you have to make sure with that is that with them, you have to watch them through life, really, because they can later on are more prone to what we call ovarian cancer, uterine cancer. And so you have to really be careful. And also, they cannot get pregnant again for 1 year. Okay? They have to wait a full year before they can get pregnant again. That's hard on a person, especially if they're up there in age and they're trying to get pregnant and this happened to them. They have to wait a whole year. And the reason why is because the levels, HCG, remember the first hormone in pregnancy? Well, HCG levels kind of escalate, they skyrocket. And with this disease, and it takes time for those HCG levels to go back down to normal. And so you want to go ahead and have her wait for a whole year before she gets pregnant. Okay. So this is just another slide that goes over in a little more detail exactly what I just said. But the treatment is you have to evacuate those cells out of there, clean out the uterus. Okay. Now, we got bleeding disorders of late pregnancy. Okay. Remember, early pregnancy was your ABs, the spontaneous ABs. Okay. Now is late pregnancy. That means 20 weeks and above, during the last part of the pregnancy, to start bleeding on you. Sure. The first one I want to talk about is placenta previa. So remember I told you about the cervix and know the anatomy and physiology? Well, this is why, because now you can imagine the cervix. Imagine that placenta that I showed the picture of. Imagine that placenta now is laying right over the cervix. That's supposed to be there. Okay, but poor little thing found his way there as an abnormal presentation. So what you see is because it's laying right there, you have bright red bleeding. Okay, so the bleeding is bright red because it's right there. Okay, and when it comes out, it can just drip out bright red. It's painless. It doesn't cause like her to have any pain. She may have maybe some cramping, but she's not going to have pain. No. So that's why we call that painless bright red bleeding. Okay. And it can be complete It can be marginal or partial, but that just means how much, when I refer to that, that just means how much of that placenta is laying over that cervix. Okay. So you can't do, remember, you can't do sterile vag exams in these kind of patients because you put your fingers up into the vagina and you touch the cervix, you'll make her bleed. Okay, that's number one. Number two, the fetal heart tone will go down too because she's bleeding, and you don't want to do that. And so you don't want this patient, remember, you don't want this patient to go into labor because when they go into labor, she has contractions, right? And when they start contracting like that, they'll bleed. So she can't have normal vaginal delivery. So what type of delivery would this patient have to have?
Cesarean.
A C-section. She has to have a C-section. You cannot have a vaginal delivery with placenta previa. Okay, so here's my picture, which I love pictures again. And so you see what the placenta is, and the placenta is laying really low. It's over the cervix. Baby's doing okay because she's not, she's right now, she's okay. You controlled the bleeding. She stopped a little bit. She's not contracting. Some of these patients sometimes have to have like a tocolytic to keep them from contracting. And so you want to make sure that the uterus stays nice and quiet so she doesn't contract. On the other hand, we have Mr. Placenta abruptio. So that's where the placenta abrupts right off. Let me see, I should have a nice picture of that. Yeah, here we go. So here we have, you see the placenta and you see the bleeding here, the hemorrhage that's in between the uterus and the wall. And you see she's bleeding. So this would be dark red blood coming out because it's higher up. See this blood up here is higher up than the placenta previa that was down low, that would be more fresh blood. This is what we call more old blood. So this is where the hemorrhage is. This occurs now when a patient has preeclampsia or a patient has some trauma to the abdomen. She gets hit in the abdomen, maybe she's a car accident, and she can have an abruptio. I've had patients that fell and hurt themselves and came in through the ER and was abrupting. Okay. So it's just another slide that shows you the different types of where placentas can be. Sorry about that. Okay. So what are my complications of risk? Well, here I put it in kind of nice format for you. But here's your placenta previa. And, the thing about placenta previa is that after they deliver, they can hemorrhage. And it's because the lower segment of the uterus, remember I showed you? Okay, the lower segment becomes thin where it was attached. And so, because there's, it's not very many muscle fibers down there. So basically what happens is that when her uterus contracts, it's weak. So she can hemorrhage after delivery. So these kind of patients you have to be very careful about. And also abruptio de placentae. Another cause of abruption could be cigarette smoking. And what I should say is also cocaine. I've had patients that were high on cocaine coming in, they were abrupting. That's hard to put to sleep when they're coming in on that kind of patient. All right. So nursing tip. What's going to tell me the difference between abruptio and a placenta previa is the pain. With abruption, you're going to have pain, okay? With abruption, you're going to have a rigid, hard stomach, okay? Then you're going to have darker red blood, okay? With a previa is painless bleeding, painless. Is bright red bleeding, okay, because it's lower in the segments, lower. And so I have to be very careful. Now, in your HESI book, which I love your HESI book, on page 214, there's a chart that compares them, and that would be something that you could look at too. All right. So if she's got excessive bleeding, what are you going to do? Well, just like anybody else on the med surg floor, anybody that comes to the ER, when you have a person who is bleeding, you want to, but they're pregnant and they're coming in bleeding, we're looking at what? The baby too. So it makes it a little bit more difficult when a pregnant woman comes through and is bleeding, because I have to worry about the condition of the newborn. So I'm going to make sure that I got NICU in my OR. I got the team ready to go, because it's usually, if somebody's abrupting, I usually have very little time to get that baby out. So I can have a good positive outcome. And that's what I want. And then, of course, you're going to always type and cross, okay? If she's new to your unit, you're going to do an RH, because I need to know if she is RH negative blood. Gonna have a NICU for neonatal resuscitation, because that baby's going to be depleted. Baby's going to have a little harder time breathing. I mean, they normally have a hard time breathing on their own after delivery. If mom's abrupting, that means they have less oxygen flow to the fetus. So baby's going to take a hit. Okay. Now, need to go over hypertension. So I want you to pay attention to preeclampsia, eclampsia. So we talked about preeclampsia already, which is uncontrollable. You have your hypertension related to placenta, which the cure for preeclampsia is delivery of mom and the placenta. Okay, baby and placenta. Mom gets drug called magnesium sulfate. Write that down. Magnesium sulfate, which kind of calms all smooth muscle fibers, which is good, but you got to be very careful with magnesium, because you can really arrest her respirations. But what I want to make sure is I'm keeping everything calm, including the brain, so she doesn't have seizures. Once mom has a seizure, she now has a condition more severe called eclampsia. Okay. So with both these conditions, they are severe. They have hypertension. They have low platelets. They have elevated liver. They have hemolysis of red blood cells. Okay. And so they're very sick patients. Plus, they have protein spilling out of their urine. And so, they're a challenge to take care of. I mean, I've taken care of a lot of ladies with preeclampsia, and, you just try to get every day, you're always ready for delivery. You're always watching fetal heart tones. And maybe you might give her an injection of betamethasone to increase the production of surfactant in the baby's lungs prior to delivery, especially when she's preterm and she's not getting any better. Doctor says, we're going to have to deliver her early. Okay, so because we want to save mom, we want to save baby. So we'll give her betamethasone, 12 milligrams, 2 injections, 24 hours apart. So you give one day, and then 24 hours later, you give the next injection, and try to increase the production of surfactant in the baby's lungs. Okay. So when you're looking at your patient, when she first comes to your, say your OB clinic, you're always thinking, is she at risk factors for gestational hypertension? There happens to be the first pregnancy, and that's so unfortunate. And then it's like, it could be the real young people, like 17, 18, they come in, they're not happy they're pregnant, they didn't plan it, so they're very ambivalent about the pregnancy, but meanwhile their blood pressure's up. Maybe they had some blood pressure problems before getting pregnant, and so now here they are, and they're stressed out. the stress over being pregnant. So that group can get real sick on you real quick. And then the age 40 and above, that, you know, our advanced maternal age patients, they can get sick on you really also. And then of course diabetes and of course kidney disease those are all kind of risk factors. So these are just systems that are affected by gestational hypertension. And if you see it, it's probably all the systems. If you notice, you have hypertension, you have edema. Remember, hands and feet, hands and face, right? Beginning signs. Protein spilling in the urine, dizziness, spots before the eyes, double vision, central nervous system disorder. Okay, when the brain gets involved, you got what? You got eclampsia, blood clotting, low platelets. They bleed out. They bleed out on you. Never good. Never good. Urinary tract, decreased urinary output. Respiratory system. They have hard time getting enough oxygen in, breathing on their own. Well, everything is affected by gestational hypertension. And of course, gastrointestinal system and the liver. The liver is get enlarged. All right. So what's your treatment? Well, it's gonna be, what do you think your treatment should focus on? Excuse me. Well, is to maintain blood flow to your vital organs. Every organ in your body needs blood. Okay. So it's dependent on that. The fetus is dependent upon mom. The fetus has the placenta, which is keeping that baby alive. So everything depends upon mom's circulatory system. And so we want to keep that flowing so that we don't have any complications. And we also want to keep mom from having any kind of convulsion, seizure activity. You always want to think, you know, when you come down to seizures, just like an epileptic, you know, you want to make sure you protect them from harm. You always want to make sure they have an airway. Now, I know a lot of students like to put oxygen on a patient like that, but no. First, you let them have the seizure. And then you always want them on their side. Of course, you want to prevent aspiration. And you just want to maintain an adequate airway. By having them on the side, you will do that. And then after they have the seizure, in order that they get a little more oxygen, then you can put the oxygen on. Okay. So you always want to read those kind of questions very, very carefully. Okay. So what's your treatment? It goes over here. We're going to watch your blood pressure. We're going to watch fetus, make sure he stays good. Make sure he's moving around. You're checking your urine for protein. Got her on magnesium sulfate. So if I have it on magnesium sulfate and it decreases the smooth muscle, I got to be very careful that I don't give it too much. So I'm going to like check reflexes, because the patella is one of the reflexes that's easy to elicit and gives you a good clue if you're getting too much magnesium. You lose the reflexes in the patella, and what do you got? You got you can have respiratory. The next system could be respiratory. So how are you going to reverse if you got too much magnesium? Calcium gluconate. I would remember that. Calcium gluconate. Okay. Bleeding incompatibilities. You have the Rh negative mom and Rh positive fetus. Remember, negative and positive, they don't get along, okay? No. And we don't really want mixture of fetal blood with mom's blood, okay? So what do you got to give her? You give her Rogam. Write that down, Rogam. And so that helps protect that fetus, and actually it protects even the next fetus. And so what she'll do is she'll get the Rogam during pregnancy, okay? And that's going to protect the present fetus. Then after she delivers, 72 hours after she delivers, she gets the next dose of Rogam. And now that's to protect the next pregnancy. So, we don't want a condition called erythroblastosis fetalis to start up. And that's what this little slide is all about, which is a good slide. And you don't want negative in with positive. What you need, Winnie?
So, is there a
Winnie?
time frame?
Okay,
Yes.
hold on, I can't hear you.
Is there a time frame within the trimester when to give the Rogaine?
Winnie, did you have a question?
Yes. Are you hearing me?
So Winnie, raise her hand.
I
Okay.
did. Are you hearing me?
Huh?
Are you hearing me?
I can hear you now. Sure.
Yeah, I said, is there a time frame when to give the Rogaine?
Yeah, about 28 weeks into
Okay.
pregnancy, we give
All right.
Rogaine. Yeah.
All right. Thank you.
Yeah, you're welcome. Good question. I should have said that. So there it is. Winnie, there it is. It's about 28 weeks, and then we give it within 72 hours after delivery. And again, the reason why is you're protecting the pregnancy, the next pregnancy, with that one after delivery. So also, when an Rh negative mom has an amniocentesis, or say she maybe has a threatened AB and she's Rh negative, we're going to give her Rogaine. Okay, it just protects the fetuses, and you have to do that because what happens is moms Rh negative antibodies, okay, it crosses the placenta, okay, they cross the placenta and it eats up all those beautiful erythrocytes. Let me go back to that picture here. It eats up all these beautiful positive red blood cells. These are erythrocytes, and so it destroys them. Well, if you destroy a baby's red blood cells, what's going to happen to the fetus? It's going to die, or when it's born, it's going to be severely anemic. So, a lot of times when this happens, and the erythrocytes are very low on the fetus, they can do an intrauterine transfusion, where they'll infuse blood into the fetus while still in mom. Now that's real risky, and I haven't really seen that occur but just one time in 45 years. But it can happen. But those are severely anemic babies. So you're going to give Rogaine, that's for sure. Okay, so then the next thing we talk about a little bit is the glucose metabolism and what the effects on pregnancy. Well, remember, you got estrogen and progesterone, and then you have HPL, that human placental glycogen, which increases what? Glucose to the fetus, because the fetus needs to grow. But we have to be very careful because of the increased resistance of cells to insulin. And then you have increased speed of insulin breakdown. So, that's why we do those tests, the glucose tolerance tests and the screening tests. First, we'll screen, and then if the mom fails the screening test, then she'll get a 3-hour glucose tolerance test. So what I want you to know now is that, if mom cannot increase her insulin production, then she'll have periods of hyperglycemia. Remember, the pancreas puts out what? Insulin. If she cannot increase her insulin during pregnancy, she'll have periods of too much sugar. So we pick that up during pregnancy. And so that's why during the second and third trimester, the fetus could be at risk, is because of too much sugar being circulated, and it can cause organ damage. And that's why you get some of these babies that are really big, and they're called macrosomic babies. So I put some really nice little chart here for factors that are linked to gestational diabetes. And so you can go over this a little bit. I want to get into a little more infections. So I'm just going to let you basically read over this. Basically, it's everything I just went over. Okay. This is the size of our babies. Too big. All right. And treatment is that you have the first line of management, monitor your glucose levels, ketone monitoring, exercise, and fetal assessment. This is what we do. We always monitor the glucose levels. And we can do ketones on her urine and tell them to exercise, get out there and walk a little bit, and fetal assessment. Okay, let me see. Let's jump here. All right. The thing I want you to remember out of this slide is that a baby just born to a mom who's a diabetic, gestational diabetes, or type 1 diabetic, that baby could be what we call macrosomic big babies. They have a strong tendency to be hypoglycemic. That means they have very little blood sugar. Now you think, well, what are you just talking about? So if I give you a Snicker bar all day long for 9 months, and so your grooves will be very big, okay, one. And number two is now you have what? You have a lot of sugar, right? Okay. But now you're born. So now you're not getting any more Snickers bar through mom. Okay. You're cut off. Boom. What happens to your blood sugar? It drops and drops suddenly. And these babies get really jittery and they're very agitated, and because they're hypoglycemic. Their Snicker bars have been cut off. They don't get them anymore. So they're going, well, where is it? Where is it? So the blood sugar just plummets. Okay. And because of that, they can get into respiratory distress. So what we're going to do is that we're going to monitor their blood sugars. Okay. Especially when they're just born, we're going to keep a close eye on the blood sugars. Now, mom can breastfeed and should be encouraged to breastfeed. So we have to be careful with those babies. And those babies, too, can have a tough time after delivery because they had probably a tough delivery if she delivered vaginally. They could have run into what we call shoulder dystocia, where the head comes out and then the shoulder's stuck. And you end up with the baby could end up with a broken clavicle because we got to get the baby out. Okay. Heart disease, we talked about, clotting factors and increase during pregnancy. And then, so that puts mom up to a problem with throwing a thrombus, or a thrombus. She could have a DVT, deep vein thrombosis after delivery. Okay. And that could be deadly. So we have to be very careful with mom afterwards, and the baby too. We don't want, patients with that pregnant, because of the increased cardiac output, there's an increased workload on the heart, can throw mom into congestive heart failure. Don't forget, she has increased fluid going on, increased blood volume, like 45 to 50%, circulating more. She has fluid retention. She's at prone to congestive heart failure. And the baby is also going to get a reduced placenta flow because of that. So remember, things that affect mom do affect the fetus. And so we want to make sure that mom and fetus stays good. So this is just a nice slide that goes over the signs of congestive heart failure during pregnancy. You might just want to give that a fast look at. And then your treatment. Well, you're going to be under cardiologist and obstetrician and probably a perinatologist. Probably going to give you diuretics and probably some beta energetic blockers, maybe anticoagulants. And you may be surprised, but vaginal birth is preferred because you have less risk for infection or a respiratory complication than a C-section. It's true. And so you may think, oh, yes, during the labor, it got complicated. So I can manage all of her. But at delivery, though, I have a decreased risk of infection because when you go in and you're cutting her open for a C-section, you're putting her at higher risk for infection, and that infection can go right to her heart and cause her to have endocarditis, and then therefore be very, very sick lady. Okay, we talked about anemia already. So again, iron deficiency. So I'm going to skip over that. And we talked a lot about nutrition. So I think I'll skip over that. I want to just hit on infections because I think we didn't do this very well the other day. We ran out of time, but I want you to take note to toxoplasmosis. That's if you're eating, mom eats raw meat, she can get toxoplasmosis. If mom has a cat and she's handling cat litter, she can get the toxoplasmosis. It is a nasty parasite, and it can cause very bad damage to the growing fetus. So this is why we keep that away. We use the acronym TORCH. So T is the toxoplasmosis, O stands for everything else under other, and then rubella is for the rubella one. We talked about that. And the cytomegalovirus is a common virus. It's like the same family as the herpes virus, but it's spread by direct contact of body fluids. Those can be deadly to the fetus. And then cause herpes. Okay, so STIs, chlamydia, we talked about going up into the fallopian tubes and doing damage to the fallopian tubes, gonorrhea, syphilis, trichomonas. None of these are good for the fetus. So we have to be very careful, and they all can be sexually transmitted during intercourse. HIV. The infant can be infected because everything goes right to baby, crosses the placenta. We call that transplacental. And also, it crosses the breast milk. It can go right to baby. So on HIV, now write this down, an HIV positive mother cannot, N-O-T, cannot breastfeed her infant, okay? All right. So what's your nursing care? Well, educate the HIV positive woman on methods to reduce the risk of transmission to her developing fetus. Pregnant women with HIV or AIDS are more susceptible to infections, as we all know now. And breastfeeding is absolutely contraindicated for moms who are HIV positive because it crosses the breast milk, goes right to the breast milk. Okay. All right. I put a little kitty cat here. He's kind of pretty though, but you can't, if you have a cat and you're pregnant, you cannot touch the cat litter. Because toxoplasmosis causes low birth weight, causes a baby to have enlarged liver and spleen, can cause the baby to have jaundice. That means because the liver is involved, yet enlarged liver. Anemia. So the baby can be very sick. Eye structures, has inflammation of the baby's eyes, and it can cause neurological damage. Again, it's a parasite. It is transmitted through placenta. So, also, if you eat raw meat, you can get toxoplasmosis. What are you going to do? So you educate the patient again. You're going to cook all your meat very thoroughly. Remember washing hands. You touch raw meat, and then, you have to wash your hands because you can't touch all the kitchen surfaces with all that stuff on it because it's all infected. So wash all your fruits and vegetables very well also. All righty, we're almost done. Group beta strep. Kind of want you to know this. It can be deadly. Okay, write that down. Group beta strep can be deadly to the infant. So where it's found is in a woman's rectum, in the vagina, the cervix. So what we're going to do is we do a culture like at 36 weeks. And if she's positive for group beta strep, during labor, we're going to give her antibiotics. Now that has sufficed, makes it better for the baby. When the baby comes through the vagina, he doesn't breathe in this positive group beta strep. So we have to be very diligent and make sure that every woman gets tested and that no babies come through the vagina through a group beta strep that's positive. We treat mom with antibiotics during labor and it takes care of it. And so after delivery, baby will get an antibiotic and mom will continue, but it's easily taken care of. But if it's not, and the baby gets exposed to group beta strep, then it can kill that baby, it can be detrimental to the baby. So that's what I want you to make sure that you understand. This just goes over urinary tract infections, and you probably know that already about the bladder, and we talked about cystitis. We talked about it not taken care of, it goes into polynephritis. So I went ahead and organized this for you so you can see what will be patient, what she would be exhibiting if she had that. Okay, so take that from there. This was an interesting one. I want to put this in there, the teratogens that can occur in the environment that could be hazardous during a pregnancy. So they can group them into A, B, and C, and then you have substance abuse and alcohol. So I thought this was pretty interesting just to kind of put it into perspective. So you can, say yourself. Trauma. Remember, we talked about trauma. It can cause a placenta abruption in car accidents, suicides, homicides, automobile accidents. Also, if a woman is in a domestic violence situation, they all are being battered. She can be prone to trauma, and then what happens is just she can have an abruption related to the trauma, and that can cause her and the baby to be definitely risk. If you ever have a patient that confides in you, it's absolutely confidential. You don't discuss it. Her life can be in danger if the abuser learns that she's told somebody. And then, you can refer her to local shelters. You can talk to her, but who actually makes the decision to leave her abuser is hers alone. We can guide them, but that's it. All right. And then now, so that becomes the end. So we did pretty good. So I'm going to stop sharing. Hope you enjoy this great review of all these chapters. I know your head's probably out to here now. I understand that. Let me just stop sharing.